Bill, would you like to act as our chair?
Can't see.
He's been on one.
There you go.
No problem. No problem. Another feeling.
So, approval of minutes from what?
First order of business is approval of the minutes of our September 20th meeting. Everybody has received a copy, and there are copies present here also available. So,
They look wonderful to me.
And the second,
okay.
just a motion to approve.
Okay.
Masonville Medical Director?
Yeah, now we have here a request for a new medical director for the Masonville agency, Dr. Thomas Cruz, C-R-U-Z. He lives in New Berlin, New York. And I have here a copy of his role and responsibilities as a service medical director form that's been filled out.
Is he an ER physician?
I'm sorry?
Is he an emergency physician?
That I do not know.
Did you get a
I know he's
CV?
required.
I thought,
Huh?
because they had asked to get a CV for these people.
What's his name?
Thomas Cruz.
Thomas M. Cruz, C-R-U-Z. Yeah, because we're supposed to get a CV and a whole,
Ah,
you know,
okay.
background, not background, a whole
Background check.
All right, what
bit of information about him.
how shall I proceed with this? Would you like me to ask them to? Let's see.
They can send it electronically. You can
Yeah,
forward it.
send it electronically, we'll forward it out to the group and we can approve it online.
Yeah, and they'll speed things up dramatically.
As long as everybody's in favor of that.
Okay.
What do they say, John?
Okay.
What do they say
All
about
it was the request form.
Oh.
Yeah, this is the responsibility form acknowledging that he had read and accepted the responsibility. Okey doke, I will do that. Now, Northampton Ambulance.
Just let him die.
Northampton Ambulance has requested an upgrade of their service from critical care to paramedic, and I'm going to let Jack Farquhar address that before the doctors.
We now have a paramedic on staff, so we'd like to move back up to paramedic service.
Is that 24/7 or
What's that?
24/7?
No,
One paramedic?
we're 24/7 as available,
Okay.
volunteers.
24/7 ALS, but it's a mix of CCT and paramedic.
Right.
Mhm.
Perfect.
Okay.
I make a motion we accept.
There you go,
Okay.
second.
Okay, as you know, in the REMAC, the doctors are the only ones who vote, so. Okay, now, Franklin Agency formally has resumed a BLS level of service, and this is informational only. They have dropped back to BLS level of service at their own request. They no longer have available ALS personnel. So, again, just informational. And Tom Pasquarelli, who has an excused absence this morning, unfortunately he cannot be here, he has to work. He made a request that there be a discussion on stroke-centered transport destinations. And maybe Trish Green could address that a little bit. He asked through Trish this morning, could this request be forwarded to the January meeting? Because we expected to be here and unfortunately could not at the last minute. So maybe Trish could just talk a little bit about background on it.
I can give you some background on it. I think he only requested that we move it in case any of you had questions, but the protocol right now for stroke patients is that EMS providers take them to a designated stroke center. We are not at St. Mary's a designated stroke center, but we now have 24-hour neurology services that we get provided through teleneurology services. And we are no longer transferring our stroke patients to Ellis. We are treating them in the hospital and keeping them there. So his concern is now we're taking these patients out of our area into a hospital that's farther away, when it really doesn't make sense when we provide that service to bypass us. You know, these patients really want to stay in our community. They want to be treated by physicians. They know they don't want to be sent 25, 30 minutes away to have the same care that we can provide.
Is St. Mary's applying for a stroke center designation?
We are looking at doing that. The application is pretty extensive. The requirements are pretty extensive. But we are researching that again. Right now, we've used teleneurology on 11 of our patients. We meet all of our targets with the exception of one patient who presented with chest pain, not stroke-related symptoms. But, you know, we're treating them. We've given TPA twice to those, you know, out of those 11 patients. One had resolution of symptoms, one did not. And we're keeping those patients in our hospital, so it doesn't make sense to bypass us.
Well, what invasive modalities do you have there?
What did you say?
What invasive modalities do you have to treat stroke?
We don't.
Okay, so
We did transfer one of them out, but it was a bleed. So we are still going to transfer those patients that need neurosurgical services, but the rest of those patients we're keeping.
invasive radiology, selective TPA, you have that, or you don't?
We do have
Selective
TPA.
intra-arterial TPA
No.
or
Mm,
anything
right.
like that? Because that's the benefit you're gonna get at Ellis and Albany Med, where they can catheterize the vessel
Right.
and give microdoses of TPA directly to the site, as opposed to systemic TPA with the subsequent risk of intracranial bleed around, 5 or almost up to 10%. I think it's around 6 or 7%.
Right. We do not have that capability.
Yeah, so that's the concern, and that's why we've always, at all our hospitals at Saratoga and Nathan Latour, we transfer, we TPA, systemic TPA, and transfer to Albany Med, because they have that higher level capability available. And when 5 out of 100 patients are gonna have a post-TPA bleed, do you really want them at St. Mary's?
Right.
So that's
And I'm not saying we're
concern.
not going to
Yeah.
transfer those patients out,
Yeah,
but they should at least be brought to us first. I mean, the first thing they need
Yeah.
is the CT.
right.
They need to, we
Right,
need
they
to see.
CT and TPA.
Right, in which we can provide that service, so why not bring them to us instead of taking them,
Right, and I've never understood the stroke center preference. I think it was designed for inner city locations where you have 2 hospitals next to each other.
Mhm.
I think that's what that was designed for. I don't think it was intended for rural locations like ours, where the next hospital is 45 miles away.
Right,
I agree that they're gonna get the same initial care in any emergency department. The additional stroke center care has to do with nursing and physical therapy, occupational therapy, speech therapy, rehab, those things, and that's where the stroke center designation and, like Bill said, the interventional stuff raises the hospital to a level above what you and I are capable of doing.
Is the Ellis group the neurologist that you have there now?
we have 2 different neurologists there, but they're not there full-time, so we do the teleneurology services. We have Dr. Chowdhury, and then we have Dr. Minhouse. Dr. Minhouse does work out of Ellis, but he works with us as well.
And the teleradiology is through where?
Specialists on call. It's
So
a
it's
company
a
based.
national
Yes,
company.
they're based out of Virginia, but they provide 24-hour service.
Thomas Cruz, I've got some information on him when we finish with that
Okay.
discussion.
Is the New York State BLS stroke thing a mandatory, or is it a recommendation? Because it's a BLS New York State protocol, it's not an ALS issue, so this would actually be a New York State issue as opposed to an AAREMS issue, I believe.
Actually, I think it's addressed in the AAREMS protocol.
It is,
Yes,
it's 2 hours.
because we just copied,
Yeah.
I think we copied the current state.
You have it there?
2 hours.
Yeah, it's a,
Yeah.
I would say it's probably a strong recommendation, and as such, it becomes,
Yeah, we'd have to go back to the Department of Health advisory on that and see how it's worded.
Right. I don't know it verbatim, so I don't wanna,
Because I know in Gloversville, they'll bring us all the strokes. They don't necessarily drive all the way to Ellis for the stroke. If it's more convenient, depending on the directions, yeah, they will. But, if you have a patient in the back of a GAVAC ambulance and you have to turn right to go 500 feet to St. Mary's or turn left to go 20 miles to Ellis, well, you just turn right.
That's our question.
Yeah.
In the city of Amsterdam, especially, are we gonna be bypassing the hospital that's within 5 minutes to go
I will.
25 minutes?
no.
Yeah,
But we
and I
need,
don't
because of
think
the way the
that's right.
protocol's written, we need
Right.
you to be able to tell us that
I-
it's okay to go to St. Mary's. And even if we develop
Yeah.
something like the STEMI alert and get them in for a CT right away,
Yeah.
and then let St. Mary's figure out if
Which
they need to
you
go.
can do, and
We already have that, we have a code neuro.
well,
Yeah,
here's,
so
here's,
Initiate when we have patients arrive. with
reading this
symptoms.
here, transport a patient with signs and symptoms of stroke to appropriate hospital. Transport to the patient to the closest New York State Department of Health designated stroke center.
Right.
If the total pre-hospital time from the patient's symptoms and or signs first began to when the patient is expected to arrive is less than 2 hours. I mean, in all honesty, Hamilton County, for example, you're over it before you even left the door in most cases.
That's right, oh yeah, we could never make that window.
Whether you go to St. Mary's in Amsterdam or Latour.
Mhm.
But
Because-
when they pick up a patient in the city who's had their onset of symptoms a half an hour ago,
Right.
the way out.
It
is-
says here, the total pre-hospital time expected to arrive is greater than 2 hours, closest appropriate. Or an online medical control physician so directs. There is an out in the
Yeah, and that's
protocol.
what I was just gonna say, and we copied the protocol exactly what Mary had just read.
Under
And
B,
the
yeah,
out is, all they have to do is call the St. Mary's ER doc and say, hi, we have an acute stroke patient, is it okay if we come here? And the ER doc says, absolutely, bring them right in, you're covered, right then and there.
it's in the protocols already.
Yeah,
Mhm.
so it's, as long as they consult the physician,
okay.
you're good.
It's M17 in the state BLS protocols, and then it's also in the,
So all suspected strokes are gonna need medical control.
basically, yes.
Yeah.
If you want to bring them to St. Mary's, or whatever hospital.
If they're within the time frame.
In the state protocol,
Good.
the basic protocol, it also states in there, define it, but it's up to this body to determine what is appropriate. We've never done that. I brought it up several times, it's never been done. What, for any, it says the same thing for cardiac, there's always that phrase, nearest appropriate facility. And it's supposed to be up to the REMAC to come up with a schedule of appropriateness of facilities, and we've never done that. If we want to designate, I would think, if we want to designate St. Mary's as an alternate stroke facility, then it could be done, and it would then become an appropriate facility.
Or I think we could look at it even more general than that and just say that the emergency department care you're gonna get at any of the emergency departments in the region is identical. You're gonna get evaluated by a doctor, you're gonna get a head CT. If you're within the window, you're gonna get TPA. If you keep them at your hospital, that's a hospital-specific protocol. If your hospital's protocol is to transfer to a stroke center because of neurosurgical capabilities, then it's an individual hospital thing. So as long as we're saying that the emergency department care is the same across the board, then we're good.
Yeah, if you're lucky enough to be within that 2-hour window, there would seem to be the state says you shall go to a stroke center. If you're outside, which is probably 95% of the patients, then the appropriate kicks in, and we could come up with a listing of hospitals. And I don't know exactly which hospitals have the capability of the teleneurology and things like that. That would, you know, and
Honestly,
what
we
do
don't
we-
think it makes a bit of difference to have a neurologist look at a patient versus me or you look at a patient.
Well, I'm just thinking of the TPA, do you still have to have a
No, it's not.
neurology?
You can
or-
administer
okay.
TPA as an ER physician.
So there are some hospitals that don't do TPA in our region.
Okay.
Do all the hospitals in Delaware have CT?
We don't have CT, but they don't do
They don't do
TPA.
TPA.
I don't think Cobblestone
And they're not
does.
staffed by physicians.
I've never
That's
seen
right,
them
some
do
of them have
TPA
PhD.
first. I don't know if they do.
It'd be interesting to look at their hospital policies and protocols on.
They bring somebody to us with a signs and symptoms of stroke, stat CTA of the head, and they'll call the closest, like either Bassett or Wilson, to do a transfer. And we usually, if the weather's convenient, we'll try to transfer them out by helicopter. And we had a great call last year where one of my basics got on scene, recognized the symptoms, had been like a half an hour, he called the helicopter in, and the patient had a remarkable recovery. But they said he had to, from the time the helicopter was called till the time the patient arrived down to Wilson was an hour and 25 minutes. So he was well within the 2 hours.
Just to clarify, is it going to be only the patients within the 2-hour window that we call St. Mary's and ask them if it's okay to come in? If the patient's outside the window, do we still have to get medical control on the phone, or is it?
I would call them about
I
everybody.
don't think you need to call if it's over 2 hours, because
Yeah.
it's out of the,
If it's out of the 2 hours, it doesn't
Right.
much matter. You're just
Yeah.
going there for.
It seems to be general practice though, don't you think, with the medics to call even if it's outside the 2-hour window? I see where they,
I don't
or
think
no,
so.
do you guys not see
We
it?
just call for Oneonta, and we've got Fox Hospital right there, and most of the doctors at Fox will say, no, just go ahead and bypass and go right to Bassett, which is 30 minutes away. And they can do the TPA as well, and they've got the CT capabilities, but the definitive care is at Cooperstown. And if it's a bleed, they're just gonna not do anything, just wasting time.
Well, that's what we do, because we, you know,
Percentage of
we got a hospital right there
Very low.
in Walton,
Very
but
low.
our closest definitive care is gonna be either Wilson or Bassett, we're both an hour away.
Beyond the initial TPA or coiling or whatever they do, is there other services that are post-incident but still inpatient stroke care services that these hospitals have? Once you get through the first 12 or 24 hours that
I
maybe
don't
St. Mary's
know,
wouldn't
and Trish,
have?
you may know what the checklist looks like if you're going through it now. I've never looked at the stroke center designation checklist, but it's huge.
The application is huge, and basically they're saying that every single member that could potentially treat stroke patients needs specialty stroke training. So that goes through your physical therapist, your speech therapist, every RN, you know, every CNA, they all have to have specialized stroke training. So it's a very extensive process.
Because, I mean, there's more than just
Not
the
a lot of
initial
gain.
first 12 hours to think about. Yeah, we think about that because that's our scope, but is there more to being a stroke center than the first 12 hours?
Yeah,
I would think, for example, at
It's the
Cobblestone,
first, it's the entire hospitalization
Right.
that
if
they're on.
a small hospital, for example, at Cobblestone, if they did the TPA, as soon as the patient was stable enough, they would then transfer them probably
Yes.
to either Bassett or Ellis for follow-up care and like that. So it would be the emergent care, the only thing that they would provide anyway.
Any other thoughts?
So just to get the clarification on only the 2-hour window, am I telling my guys to call the doc, or unknown, if they wake up in the morning like that? Are we
To
just
wake up
going-
in the morning like that, you're out of the,
You're out of the window.
that's it, you're out of the
So
window.
anything that's out of the window, they can go to St. Mary's. If they're within 2 hours, get medical control on the phone to see.
And they can still go there if the doctor needs to tell them. And my guess is your physicians are gonna be instructed just to tell them,
Yeah,
it makes
we won't,
sense.
we won't say no.
We can
essence, it's call for everybody. Because you're gonna call them to tell them you're coming anyway.
Right.
So you don't need to talk to the physician.
I don't
You don't
need to talk to the physician, I
physician.
just tell them when I'm coming
Yeah.
with the unknown
Yeah,
time,
Yeah.
stroke symptoms.
that's true. Yeah, good point.
So you
But
just
actually
need
get a
medical
doctor on the phone
control.
for
Yeah.
2 hours.
Right.
For the within 2 hours.
And this is for Nathan Latour as well, correct? Or
No, we
just-
want everybody.
I know you do.
Too far to drag to Ellis.
Yeah.
I agree.
We
For,
can-
for you guys, I wouldn't change anything, I would just
Yeah.
do exactly what you're doing now.
It seems to work. Work well, so, okay.
We can carry this topic forward to January also, if you like, just for further discussion. But, okay, Beth, you had...
I found Dr. Cruz. He graduated from Temple University School of Medicine with emergency medicine in 2003. And right now, they list his only active license as in the state of Ohio in 2009.
And what website is that?
AVVO, EVO.
So he's not licensed in New York State?
I can't say whether he is or isn't. I mean,
Oh.
that's,
Well, New York State
it shows
Yeah,
a
go to-
2009.
Just Google New York State
Yeah.
physician profile.
Yeah.
NYS physician profile.
You're gonna see
And that'll
Dr.
take you to a
Dutal's
website.
picture on the front page of that.
The big red circle and the line.
It says anything about cheap Viagra.
While Beth is researching that, our next item is an update on the EMT intranasal Narcan demonstration project, or demonstration program. All of the EMT intranasal Narcan training supplies have been distributed to Fulton, Montgomery, and Delaware counties, and Otsego and Schoharie are going to be given out today. I have them out in the car. The supplies include a pre-test, a post-test, a participant's manual, and an instructor's manual. And they sent me a whole big box of little zipper bags with a pair of gloves and a face mask in them. And I have no idea why they did that, because there aren't nearly enough to cover all the basic EMTs in the region. We have about 860 basic EMTs in the region, not nearly enough for that. And I have no idea, but because these things would not be used in a classroom setting, so I'm just giving them out willy-nilly. And they sent me a whole supply of preloads of Narcan, some of which you remember that was the boxes I got from you. Some of those expired June of 2011. And I presume that they're meant to be used for training purposes, so I've been distributing those accordingly. And they also have the little atomizers, which I've been distributing accordingly. So those materials will be given out. And I just found at the bottom of the box the pre-test, the post-test I gave out. I just found the pre-test, so I'll give those out to Delaware and Fulton, Montgomery counties this morning. I got them.
There was no test or anything in that degree.
It was
Donnie,
post-test. It was a post-
I have
post-survey.
Jay back,
I got
but
the
you were on
pre-test.
vacation, so just come see me when you get a chance to know.
All right.
Anyway, that's where we stand right now. I haven't heard any feedback from other counties. One of the counties in this demonstration project is Suffolk. And of course, Hurricane Sandy has just beaten them something terrible, so I don't know what, if anything, outside of emergency rehab is going on in Suffolk County right now. Regrettably, I just don't know. But I haven't heard anything from the Capital District about them either. Maybe Rich would be able to comment on it.
I know it's been very successful. Dr. Daly got a report. He gets a report every time somebody uses it somewhere.
Oh.
And I know they're very happy with it. It's being used other parts of the state that are not even associated with REMO. It's kind of a caught on fire, and other agencies are using it. Long Island, places that are not even associated with REMO. I know that a lot of the paramedics in REMO are using it. Instead of attacking, putting a line in somebody, they just spray it with some Narcan. It's much safer, and then you step back, you don't have to worry about needles or IVs. When they wake up and start swinging, if they give too much, they basically have no sharp instruments they have to worry about, or any kind of anything else that's in the room. They just give them a quick spray and step back and get out.
That's right, if they hit you with an atomizer,
Yeah.
it's not too bad.
So
Get out of the way of the
they actually,
projectile
REMO,
vomiting.
if you need more training videos or anything, REMO's got a whole bunch of CDs and all kinds of stuff and folders for that stuff.
Oh, okay, there is a, in the teacher's manual that I've been giving out, there is a, as you know, there is a, Rich knows, there is a training CD.
Yeah, if you need more of those boxes, I'm at REMO.
Okay, good. So anyway, it's going forward, and it would have gone forward over the summer, except we had this rather serious crisis of no money over the summer because of the state late payments. We couldn't, literally couldn't buy postage stamps for a while there. So in any event, it is going forward.
Is there a hope that's gonna be a New York State BLS protocol, nasal Narcan or something integrated like it's, or where'd she go?
That's what the plan was to gather data on it and effectiveness and submit it to the state. But
I see it coming.
Yeah,
I see it coming down.
a couple
Sure.
months ago, it was mentioned that there were somewhere around 30 or 40 administrations of it, not counting New York City.
The city, I guess, works much better, it's been
Yeah.
quite a bit. Also CPAP too, supposedly should come out eventually for BLS, I guess it's very popular right now too. It's, a lot of physicians are supporting that, so.
Combine the two.
Oh, you got, I'm sorry, Beth.
Yeah, he is licensed in New York as of 9/2007. He graduated from Temple University in 2003, went to Eastern VA Medical School, completed emergency medicine in 2006, and it looks like he's working out of Shenango Memorial Hospital.
It's not a position too.
It's not a position for this.
Some of them, there should be like a series of this one.
No.
But at least now we know he's
Okay.
practicing ER doctors, but they do need to send us a CD for the
Sure.
file.
I'll get a hold of it.
Yeah, yeah.
You want to approve?
Yeah.
Pending receipt of, yeah, because
Yep.
you got all the bona fides, okay.
That's fine.
Yeah.
I'll have them send, yeah, Mason was very good, they're very responsive.
Then it's not somebody, not just a contact.
Yes.
Under old business, I have an update on any protocol feedback. We have not received any protocol feedback in the last 2 months since our September 20th REMAC meeting. Has anybody anything about the narrow banding mandate? I found out something interesting from my radio technician. Narrow banding will not involve changing frequency numbers. The numbers are going to stay the same. So for example, a hospital frequency is going to remain at 155.340. It's just that it's going to be, so to speak, a narrow 340 instead of a wider one. It's going to be 12.5 instead of 25 kilohertz wide. And what does that mean for practical purposes? It usually means that, and what little I know of it from personal experience with our radio system up in Hamilton County, it usually means that the reception, you got to turn the volume up. The reception is a little bit low. Volume goes down. Outside of that, you can't really notice any differences.
Usually the voice quality gets pinched sounding. It gets a little more, it sounds more like you're talking to somebody on the telephone than on a radio, that's all.
Okay, we have a couple of items for executive session, but is there any other old business to be brought before us?
I have a question. Person who orders supplies for our ambulance, for the BLS supplies, yesterday said he'd ordered the Epi auto pen injectors. And when he got the auto pen injectors, there are 2 doses of epinephrine. One of them is an auto pen injector, the other one is a syringe. BLS provider is not allowed to use a syringe, right?
Right. It comes in the auto pen?
It came in with the auto pen.
Really?
I'd never seen it before, and so he took it apart and showed it to me. I said, well, BLS people can't use a syringe.
Right. Right. Except for the intranasal atomization.
Is the syringe pre-loaded?
Yeah.
That's right.
Yeah,
Is this the little red case?
No, this
Or
is
is
blue.
this-
ours is blue. Did you look in? No.
Do you know how much they work?
I'm sorry?
Cost-wise?
They're expensive.
EpiPens are very expensive.
No, but this kid, like, is it the same price as just getting an EpiPen, or is that like a bonus, you know what I mean?
Oh, that I
Would it
don't
be the
know.
same price just to get one?
Well, it does say that it's a 2-pack. You can't buy a
They
single.
always come in packs.
Right, but there's one auto pen injector. and then the other.
And there's a regular syringe and a needle.
Yeah.
In case the auto pen falls.
Right.
So, I said, well, I'm pretty sure that BLS people can't use them, so he said, well, he told me I can send them back if we can't use them. I said, well, yeah, I would send them back.
That's funny, we just recently got a restock from Nathan Latour, and it didn't come through that way at all, it came through as regular.
This came through with the auto pen and a training kit
Oh.
and an extra syringe.
That's fancy. Did you
What
get the
did
bill
the
for it
company
yet?
say when you called them, when they called them up? Did they call the company back and say you sent us the wrong stuff?
No,
We can't use it?"
he asked me about it because they got it in the mail yesterday and he asked me about it and I said, no,
Yeah.
Who do you order your supplies from?
I don't know where he got this one.
India.
We used to,
Mexico,
we used to
right?
order them through more medical, but I think we're using Boundtree now, but I'm not sure.
Get things real cheap from them.
So,
Kind of stuff with more, because
Well, I'm surprised that they would do that for anyone though, because you want the injector, it just makes sense that.
yeah.
Yeah.
But even with the training kit, I thought, well,
You
what are you
were-
doing now? Give them a training shot before you get the real one?
I can see hand preloads.
I don't
Republic.
I don't understand, we get a EpiPen through a tour.
That's funny, this was a recent stock we got, and I think it was just a regular standard. auto pen.
Send them back and tell me what to write back.
That's what I was pretty sure that BLS wanted to go syringe.
Yeah,
Mm.
we want what we ordered.
well, that explains why the Epi auto injector got put on the shortage list then.
I wonder,
Sending out too
maybe,
much.
maybe.
I see that on the list.
Yeah, because epinephrine has been on the list for a long time, and now they're just
Oh, I
probably
just see it
preferentially
getting,
bottling it in.
yeah, and that's
Cardiac
going on the
stuff.
list, and then, so we just won't have any.
Yeah.
We got a 3.5 pages from our pharmacy about the medications in the back.
I just sent out something to everybody yesterday by email, an updated back order list on medications from the Nathan Latour Pharmaceutical Department, just for information. There's huge quantity
Pretty
of stuff.
extensive.
The auto injector is not on this list.
No, and I printed off the one that's on your website, the FDA, the one that's like 40 pages long of different meds.
Oh, that one, oh, okay.
That has every epi there is available in any way, shape, or form seems to be on there.
Yeah.
All right, what's next?
Okay, well, the next is I have a few items to be discussed in executive session. So if I'd ask the REMAC members to join me in the bar and the rest of the fun, this is on tape, so I'm going to hear from somebody about this. We will be back shortly. It's not a lengthy executive session at all.
I printed that out. Okay.
On a chainsaw. I'm like 90% better with that car.
I went through the 40-page one and made that the list and put the excuses.